Okay, so next is Barrett's esophagus. It's V3. So before starting the clinical equation, so we are going through some basic science. So Barrett's esophagus is a pre-malignant condition with 30 to 50-fold increased risk of malignancy. However, the actual incidence of cancer within Barrett's esophagus remains low. The annual rate of progression from non-dysplastic Barrett esophagus to adenocarcinoma is approximately 0.22% to 0.38% per year. And the sequence of carcinogenesis follows from intestinal metaplasia to low-grade dysplasia to high, followed by invasive malignancy. And early esophageal cancer is defined as a cancer contained within the superficial component of epithelial lining and without lymph node involvement. It includes T0 or T1A mucosal and T1B submucosal adenocarcinoma. However, the risk of lymph node mets in T1 adenocarcinoma is 0 to 10%, and T1B carcinoma is up to 46%. Okay, half of the patients with T1B might have lymph node mets. Okay, so let's proceed towards the Barrett esophagus. You perform an upper GI endoscopy on a 48-year-old man with symptoms of acid reflux and discover he has a Barrett esophagus. What is Barrett esophagus and what is its significance? So 3 points, guys. Number 1, Barrett esophagus is endoscopically visible change in the lower portion in any portion of the normal squamous esophageal epithelium at least 1 centimeter above the gastroesophageal junction to metaplastic columnar epithelium confirmed on histological examination. Point number 2, it's found more commonly in endoscopy for symptoms of gastroesophageal reflux. This is the leading cause of Barrett's metaplasia. The theory is that, last point, that acid injures the squamous epithelium of the esophagus and subsequent repair occur, but the abnormal acid environment affects the healing and columnar cells replace the native squamous cells of the esophageal epithelium. How would you assess the Barrett esophagus at endoscopy? So there are 2 things to mention here. First, we have to document properly by using the Prague C and M criteria, that the maximum circumferential from the gastroesophageal junction and the maximum length, including the tongues, not the islands, from the gastroesophageal junction. So Prague C and M criteria: C for circular, M for maximum length. And systematic biopsies of Barrett esophagus are needed to assess for dysplasia changes, and this is called CETL protocol, that 4 quadrants biopsies every 2 centimeter above, depending on, for example, if Barrett is 4 centimeter, then we will take 8 biopsies, 2 from the lower 2 centimeter, 4 from the lower 2 centimeter and 4 from the upper 2 centimeter. And all biopsies should be graded histologically. This then determines the interval of surveillance. Histology confirmed Barrett esophagus with intestinal metaplasia. How would you counsel and manage this patient? First of all, I will see the patient in clinic in 4 to 6 weeks time, and I will explain that there is a low but significant risk of cancer, and I will advise him lifestyle changes, indication for surveillance, and possible treatment options. I will start PPI. And according to the 2013 British Society of Gastroenterology guidelines on the management of Barrett esophagus, the frequency of Barrett esophagus depends on the length and the metaplasia, type of metaplasia. Patient with segment 3 centimeter or longer should receive OGD every 2 to 3 years, and the patient with segment less than 3 centimeter should have 3 to 5 years. And if a patient has less than 3 centimeter gastric metaplasia, repeat biopsy should be taken, and if this confirms the absence of intestinal metaplasia, then the patient can be discharged, as the risks of endoscopy probably outweigh the benefits. At a follow-up OGD in 2 years, the repeat biopsy indicates progression to low-grade dysplasia. How does this change your management? So this gentleman should have surveillance in next 6 months OGD with systematic biopsies. If on the 6 monthly surveillance OGD shows again low-grade dysplasia second time, the patient should be discussed in the special upper GI MDT and should be offered endoscopic ablation. And there is evidence of emerging that radio frequency ablation, RFA ablation reduces the low-grade dysplasia, the rate of neoplastic progression. If repeat OGD at 6 months showed non-dysplastic changes, the 6-monthly surveillance should continue until patient has 2 consecutive non-dysplastic biopsies. Okay, so let's start again. Barrett Oesophagus, surveillance colonoscopy at 2 years, found low-grade dysplasia, book for next 6 months. At the first 6 months biopsies, either they are positive, then he should be offered after discussion immediately after some intervention. If at 6 months surveillance OGD non-dysplasia, then he should be booked again for 6 months until 2 consecutive 6 monthly biopsies are negative for dysplasia. Then he should be reverted back to normal screening. Further surveillance biopsies demonstrate areas of high-grade dysplasia within the Barrett Oesophagus. How will you manage him? So again, I will discuss an upper GI MDT to confirm high-grade dysplasia with expert GI pathologist. The standard of care used to be esophagectomy. However, endoscopic mucosal resection is now considered appropriate management for macroscopic esophageal mucosal abnormalities, followed by radiofrequency ablation if visible lesion has high-grade dysplasia or T1A cancer within. If T1B or greater cancer is within the lesion, then patient should be considered for surgery, because if you remember, we said in the beginning of this video that T1B has 46% chance of lymph node mets. Okay, thank you.